Welcome to the training module on urethral and anorectal discharge. I am Dr. Leon and I will be guiding you through this topic. Let's begin. This topic will cover the common causes of urethral and anorectal discharge and formulating an approach to these patients, diagnostic approach, treatment and management options, as well as education and counseling on STI prevention. According to WHO data in year 2020, it was estimated that 374 million new sexually transmitted infections occurred in people aged 15 to 49 years old. More than 1 million curable sexually transmitted infections are acquired every day worldwide, the majority of which are asymptomatic. An estimated 8 million adults between age 15 to 49 years old were newly infected with syphilis in 2022. 1.1 million pregnant women were estimated to be infected with syphilis in 2022, resulting in over 700,000 congenital syphilis in newborns. Did you know that a high percentage of STIs are asymptomatic? Patients could have an infection for many years without even knowing it. About 50% of bacterial vaginosis and trichomoniasis infections show no symptoms. 75% of women and 50% of men with chlamydia are asymptomatic, while 50% of women and 10% of men with gonorrhea are asymptomatic. Therefore, it is imperative for healthcare providers to notify these communicable diseases to help curb the spread by treating contacts. The common causes of urethral and anorectal discharge are gonorrhea, chlamydia, non-gonococcal organism, and lymphogranuloma venereum. STIs which have similar signs and symptoms are grouped into syndromes. This syndromic approach to ensure a quick and effective treatment could be initiated for the patient on the same day. However, we have to keep in mind that using this approach can sometimes result in overtreatment and missed asymptomatic infections. Let's go through some case scenarios to help you better understand and apply the approach in clinical practice. Our first patient is Ahmad. He is a 30-year-old carpenter. He presents to the clinic with complaints of painful burning sensation during urination for the past 1 week. He also reports a purinal discharge from the penis, which he noticed a few days ago. Ahmad is concerned because his symptoms have not improved and have become increasingly bothersome. He mentions recent unprotected sexual intercourse with a new partner. Ahmad has had one new female sexual partner in the past month. He has not used condoms consistently. He has had a total of 3 sexual partners thus far from previously stable relationships. He has no history of STIs or recent sexual health screenings. He is generally healthy with no chronic conditions and he is not on any medications. He does not use any recreational drugs or engage in other high-risk behaviors. On physical examination, he appears uncomfortable due to dysuria. Abdominal examination revealed no significant findings. There is purulent discharge from the urethral meatus. The penile skin and scrotum are normal with no signs of rash or swelling. There is tenderness at the urethral meatus on palpation. What is the next step in management? Pause the video and think about your answer before proceeding to the next slide. Depending on your clinic setting and resources, there are several tests that you can order. Gram staining and culture and sensitivity is readily available in most local health clinics, while NAAT is available in private clinics and labs. It is still acceptable to order a urethral swab even if there is no discharge seen on examination if you suspect the patient has an STI based on history. Treat the patient first and advise abstinence or condom use until the culture results are reviewed. It is also important to screen for other STDs like HIV, hepatitis B and C, as well as syphilis. A gram stain of this patient's urethral swab shows intracellular gram-negative diplococci, which is indicative of gonorrhea. Urethral swab for culture and sensitivity was sent on the same day. How would you manage this patient next? Pause this video and think about your answer before proceeding to the next slide. The preferred treatment for this patient would be IM ceftriaxone 500 mg stat plus oral doxycycline 100 mg BD for 7 days. It covers for both gonorrhea and chlamydia while awaiting culture results. Oral azithromycin is no longer the preferred treatment as there has been an increasing resistance towards azithromycin. Azithromycin is only used as an alternative treatment at a higher dose of 2 g stat in combination with IM gentamicin. For pregnant patients, azithromycin 1 gram stat is given instead of doxycycline. Do remember to check for antibiotic allergies before deciding on course of treatment. This patient has gonorrhea. The incubation period is 1 to 14 days. Men become symptomatic earlier compared to women. Patients with rectal or pharyngeal gonorrhea infection are asymptomatic in 85 to 90% of cases. Men often present with purulent urethral discharge and dysuria. They can also present with signs and symptoms of proctitis, epididymoorchitis, prostatitis, inguinal lymphadenitis, penile edema, or balanitis. Women usually present with nonspecific purulent vaginal discharge and dysuria. They can also present with intermenstrual or postcoital bleed, dyspareunia, lower abdominal pain, signs of pelvic inflammatory disease, or proctitis. When gonorrhea infections are untreated, it can lead to complications such as pelvic inflammatory disease, ectopic pregnancies, infertility, infection of accessory glands, periurethral abscess or fistulas, urethral strictures, perianal abscess, and perihepatitis. Another complication is gonococcal conjunctivitis. There is profuse pus-like discharge from the eyes with crust formation, usually seen upon waking up in the morning. You should also look out for signs of disseminated gonococcal infection such as fever, pustular skin lesions, asymmetrical arthralgia, septic arthritis, tenosynovitis, hepatitis, myocarditis, endocarditis, and meningitis. These are the investigations we send for gonorrhea infection. Gram staining is appropriate for urethral, endocervical, rectal, pharyngeal, or conjunctival specimens using a cotton-tipped swab smeared onto a slide. The presence of intracellular gram-negative diplococci is indicative of gonorrhea. We should also collect samples for culture and sensitivity using the charcoal swab. It provides useful information on antimicrobial susceptibility and monitoring of emerging resistance. The image shows a comparison of two culture media types used to grow Neisseria gonorrhea bacteria. Note that the non-selective chocolate agar medium on the left, due to its composition, allowed for the growth of organismal colonies other than those of Neisseria gonorrhea, while the selective Thayer-Martin medium on the right, containing antimicrobials that inhibit the growth of organisms other than gonorrhea, shows no overgrowth, but is positive for Neisseria gonorrhea bacteria. Nucleic acid amplification test has high sensitivity and specificity for both symptomatic and asymptomatic patients. Samples can be self-collected or collected by the physician. All individuals with gonorrhea diagnosed by NAAT should have cultures taken from infected sites for susceptibility testing prior to treatment, but treatment should be administered without waiting for culture results. Other aspects of management include advising patients to complete the entire course of antibiotics even when symptoms improve. Notify your local health district office for further contact tracing and treatment. Encourage patients to inform all recent sexual partners so they can be tested and treated if necessary. This helps prevent reinfection and the spread of the disease. Sexual partners within the last 60 days must be epidemiologically treated, irrespective of the test results. Patients are advised to use condoms with sexual partners from the start of treatment until 7 days after they and their partners have completed treatment and symptoms have resolved. All newborn of mothers with gonorrhea must be screened for gonorrhea. Test of cure is recommended 7 to 14 days after completing treatment only for patients with pharyngeal gonorrhea and patients treated with anything other than the first-line regime where antimicrobial susceptibility is unknown. Test of cure is not necessary for cervical, urethral, or rectal gonorrhea. Symptoms that persist after treatment should be evaluated by culture for gonorrhea and antimicrobial susceptibility testing. Now we move on to the next case. Joe Chan is a 28-year-old software developer. He presents to the clinic with complaints of a burning sensation during urination and a white cloudy discharge from his penis, which began 1 week ago. He has occasional discomfort in the lower abdomen, but he does not have fever or chills. He has had multiple recent sexual partners and inconsistent use of condoms. Joe recently had unprotected sex with a new partner approximately 3 weeks ago. On physical exam, his vital signs are within normal limits. There is white cloudy discharge from the urethra. There are no lesions or ulcers on the penis. Testes are normal in size and consistency. There is no swelling or tenderness. Rectal exam was not performed. His investigation results show leukocyturia with traces of blood in urine. Urethral swab microscopy showed increased polymorphonucleosides but no gram-negative intracellular cocci. Urethral swab for gonococcal and chlamydia cultures was sent. What should be the next step in management? Pause the video and think about your answer before proceeding to the next slide. According to the algorithm, you should treat the patient on the same day with antibiotics. Chlamydia trachomatis is the commonest bacterial STI, and the prevalence is highest in persons aged below 25 years old. The majority of infections in both men and women are asymptomatic. The incubation period is 7 to 21 days, but is usually shorter, between 5 to 15 days. Symptoms in men include mucopurulent urethral discharge, dysuria, epididymoorchitis, anorectal discomfort, and discharge. Symptoms in female include mucopurulent vaginal discharge, dysuria, intermenstrual or postcoital bleeding, lower abdominal pain, acute and chronic symptoms of pelvic inflammatory disease, cervicitis, anorectal discomfort, and discharge. These are the list of complications of untreated chlamydia. Gram stain for chlamydia is non-diagnostic, but microscopy usually shows increased polymorphonucleosides. Culture and sensitivity should also be collected using charcoal swab from urethral, endocervical, vaginal, rectal, or pharyngeal sites. Nucleic acid amplification tests for chlamydia can be done in private labs and are highly sensitive and specific. This patient should be treated with oral doxycycline 100 mg BD for 7 days. For pregnant patients, azithromycin 1 gram stat dose is given instead of doxycycline. Patients should be instructed to use condoms during sexual intercourse until both they and their sexual partners have completed treatment and symptoms have resolved. Sexual partners within the last 60 days must be epidemiologically treated, irrespective of the test results. Newborns of mothers with chlamydial infections must be screened. Test of cure for chlamydia is not routinely recommended for uncomplicated genital chlamydial infections because residual non-viable chlamydial DNA may be detected by NAAT for up to 4 weeks following treatment. Test of cure is only recommended in pregnancy, where poor compliance is suspected, and/or where symptoms are persistent. The test is performed at least 4 weeks after treatment completion to prevent false positive results. On follow-up 3 weeks later, Joe reports persistent urethral discharge. Pause this video and think about the questions you would like to ask the patient before proceeding to the next slide. For patients presenting with persistent urethral discharge, take a detailed and most recent sexual history to assess for reinfection. Also confirm with the patient if they have been compliant to the treatment regime. On further questioning, Joe denies any recent condomless sexual intercourse, and he had completed a 1-week course of doxycycline. Review of his laboratory results from the last visit revealed no growth on urethral swab culture. In cases of persistent urethral discharge, consider other non-gonococcal urethritis such as Mycoplasma genitalium, Uriplasma, Trichomonas vaginalis, adenoviruses, and herpes simplex virus. Joe had already been treated with doxycycline for 7 days. According to the recommendation, the patient should be covered for Trichomonas and Mycoplasma genitalium infection. The treatment includes oral metronidazole 400 mg BD for 5 days, plus oral azithromycin 500 mg stat, followed by 250 mg OD for 4 days. In the final case scenario, we have Rohan, a 22-year-old student. He complains of a persistent discharge from his rectum for the past 2 weeks. The discharge is thick and yellowish, associated with itching and discomfort in the anal region. There is no significant changes in bowel habits, no recent diarrhea or constipation. Rohan practices insertive and receptive anal intercourse with his current partner of 6 months, but uses condoms only occasionally. There is no recent history of high-risk sexual activity. On examination, he appears well-nourished and vital signs are normal. There is no tenderness or abnormal findings on abdominal examination. There is noticeable yellowish discharge at the anal opening with mild tenderness in the anal region. There are signs of irritation on rectal exam, but no masses or lesions noted internally. What is the next step in your management of Rohan? Pause the video to think about your answer before proceeding to the next slide. According to the guidelines, it is recommended to proceed with a rectal discharge gram stain or an AAT, as well as a culture and sensitivity. Offer same-day treatment to the patient, covering for gonorrhea and chlamydia. Screen for other STDs, educate and counsel for condom use. Treat the patient with IM ceftriaxone and doxycycline as per the recommendations. Doxycycline course should be extended to 21 days in total in the presence of bloody discharge, perianal or mucosal ulcers, and/or tenesmus. Give the patient an appointment in 7 days to review the symptoms and culture results. If the rectal chlamydial test is positive, the doxycycline course should be extended to 21 days in total. If the rectal discharge is persistent, consider treating for LGV, whereby the course of doxycycline should be extended to a total of 21 days duration. If the patient has anal or perianal pain or ulcer is present, also consider treating for herpes simplex. In summary, accurate diagnosis often involves a detailed patient history, physical examination, and targeted laboratory tests. Treatment should be tailored based on the specific etiology, and patient education about prevention and follow-up care is essential to ensure optimal outcomes and prevent recurrence. Addressing these symptoms promptly and effectively can not only alleviate discomfort, but also help prevent more serious complications and transmission to partners. Always test for other sexually transmitted diseases, and don't forget to notify the Public Health Department about notifiable STDs. Congratulations on completing this module, and thank you for listening.